all had restful nights by His grace. And it's indeed my pleasure to welcome everyone that has taken it as a point of duty to come this early, even to know more about what's happening to family planning, financing family planning in Nigeria. Yes, this session, half of the, one of the two sessions that I'm chairing is actually talking about what Nigeria has done as far as the global financing facility is concerned. I am co-chairing with the Director, Health Planning, Research and Statistics in the Federal Ministry of Health. I'm the Director, Family Health Department. I'm Dr. Adebimpe Adebiyi, as I've been introduced. The Global Financing Facility is actually a facility in the World Bank that has been entrusted to the World Bank by development partners, donors across the world who are interested in sustaining national developments for the overall well-being, for universal health care coverage, and for the overall well-being of the people of the world. And Nigeria is one of the second wave of countries. Some countries have gone ahead of us because it has been realized that the local resources may not actually get us to where we desire to go or where we are expected to get to. And that is why this is coming. And particularly the World Bank, in its own ingenuity, has given like a catalyst for countries that have expressed interest, a catalyst like a startup fund that that the countries will use as proof of concepts to develop their framework for the strategies that they're going to use to advance their healthcare system. For the Nigeria country platform, we have all the stakeholders represented, the government, the private sector, the CSOs. Some of the panelists this morning will be talking from their own points of view and their contributions, their roles in assuring that the GFF is implemented in Nigeria. And like I said, there has been an advancement of 20 million, which is like a grant, 20 million US dollars, which is like a grant to Nigeria for us to have a proof of concept. And we had in one of the sessions yesterday, when the Director, Health Planning, Research and Statistics was talking about the Basic Healthcare Provision Fund, even before we could secure the 1% consolidated revenue fund from the appropriation, the GFF has advanced 20 million US dollars, and we have other partners that are interested in Nigeria and want to support. We have the Gates, Bill and Melinda Gates Foundation that has advanced also $2 million. All of these monies are, their processes are at the advanced stage, and these are to be used to pilot the Basic Healthcare Provision Fund. Initially, there were 3 states identified, but with more expression of interest by the states. We have 6 states, and the basic healthcare provision fund will be implemented with this initial funding before, with additional to the 1% consolidated revenue fund from the federal government's appropriation. For us in the Federal Ministry of Health, we are aligning everything we are doing with the National Strategic Health Development Plan. And in that National Strategic Health Development Plan, we have a very vital component, which is the reproductive, maternal, newborn, adolescent, and child health plus nutrition strategy. That strategy is a very vital component of the National Strategic Health Development Plan 2, which has been approved by the National Council on Health, and we are using that. We have actually submitted that as our country investment case. And we were informed yesterday that the basic healthcare provision, the minimum healthcare package that has been approved includes family planning, which is our concern in this conference, apart from treatment for malaria, immunization, antenatal care, and some other screening for hypertension and diabetes. So I think I should stop here, and because we have a short time for this session, I want to ask the other panelists that are here to let us into their roles in the implementation of this GFF. Thank you. Dr. Umar Yaradua.
Thank you very much, Dr. Adebiyi. So as Dr. Adebiyi has highlighted, the GFF is actually a very country-driven process, which the government of Nigeria has actually taken up very well. It's trying to align the private sector, government, donors, and CSOs to actually work together to achieve a driven set of priorities that the country has identified. As she has said, part of what the investment case in Nigeria is talking about mainly is going to be done in a phased process. The first phase of this, which was an initial 20 million, went to the northeast of Nigeria to actually help there's a project currently going on there, the National State Health Investment Project, NSHIP. So the first 20 million went there to address the 6 northeast states, to address the Boko Haram issues. The second 20 million, as Dr. Adebiyi has highlighted, would be used for the Basic Healthcare Provision Fund. The third phase of the investment case is basically to try and see if all the more states will be brought up rather than the first 6 states. Then that will be the next 37 plus 1 states in Nigeria. The fourth phase would actually be looking at stunting, which is a nutrition project. Within that nutrition project, there's also an adolescent health component, which will also look at family planning, and this will be piloted in 12 states in the initial 5 years. Then the fifth phase will actually look at areas of actually increasing the basic minimum package of health services within the 36 states. So the private sector has actually been very vital to this process as well. They're actually also piloting a few interventions within the Northeast, which is part of the investment case. So Dr. Kulaja, could you also help us?
Thank you very much. When we look at the role of the private sector in being able to support governments in the distribution of FP services, the private sector, it's divided into 2 in terms of the organizations that support that process through innovations and the organizations that are also available to provide services. It's of no news that most people are, over about 60 to 70% of people access care from the private sector. And if you also look at the distribution of those that access care from the private sector, about 40% of those people are in the lowest quintiles. And so it's important to consider the role of the private sector in delivering this service. Governments are also increasingly appreciating the role of the private sector, and through several initiatives, they are looking at one, partnering with the private sector to revitalize defunct primary healthcare centers to see how that can improve or penetrate services that are delivered. And second of all, through the health insurance programs that are being set up by several states, the private sector would also be contracted in conjunction with public facilities to deliver these services. And so that shows that the private sector is going to play a huge role in pushing this agenda forward. There are also several initiatives that are coming up to support this process. For example, the Farm Access Foundation has an innovation that would sort of standardize the quality of services. You have Riders for Health looking at logistics. You have Instrat looking at how it can support the process of training people through electronic medical records, through several protocols. And so it's definitely a partnership that should work, because, and I think that it's impressive that governments are beginning to realize that they cannot do this alone and must leverage on the structures of the private sector to push this agenda forward.
Thank you. The civil society have been there from the beginning, the middle, and I guess they'll see us all the way down to implementation. So can you please tell us your role?
Okay. Thank you, and it's a pleasure to be representing the CSOs on this platform to discuss how well we've been part of the implementation of the GFF in Nigeria. The GFF came in, and it's nice for us to all know that the CSOs were actually very vital. They played a key role in ensuring that the investment case for the GFF was actually developed and planned along with CSOs. We had a role with it. And we are not just talking about the development of the investment case. The key role of civil society is to ensure there's inclusion, there's accountability, and there's participation in all through the process of the GFF. And these will actually ensure that we are able to bring in the various stakeholders from the side of citizens. The CSOs have like what we call the GFF CSO working group, which actually brought experts within the CSO to give the technical assistance to the implementation. And in this process, we've been able to support in terms of accountability by tracking the release. Even in fact, we track the document to ensure the document aligns with the National Strategic Development Plan. And we actually ensure that the indicators that were actually highlighted are actually speaking to the realities of the Nigerian state. Furthermore, we've actually had scorecards that speaks to the issue of release, that speaks to the issue of alignment, that speaks to the issue of participation. Even though Nigeria really appreciate that GFF has been the catalytic fund for the inclusion of the Basic Healthcare Provision Fund in the 2018 budget. But we still need to ensure that we are going to ask for more as CSOs, that the money needs to be released so that the project can kickstart in the 6 states as pilot and FCT, and why we are going to be working with them to ensure that when it comes to phases of expansion, the lessons learned from these pilot states are not lost, because we already have a case whereby most time when we pilot, our ability to take the lessons forward to improve on processes and implementation strategies most times are lost. So the CSOs are well placed and strategically positioned to ensure the lessons across these other states are replicated and we don't repeat those mistakes we might make. But even though now we are ensuring that we do not make mistakes, because we cannot afford to waste this resource. Furthermore, the CSOs are also ensuring to align to reduce the issue of fragmentation in funding, because if you look at the space we have in the RMNCH plus N, we've seen that there's a lot of players in this sector and there's need for alignment. One of the key issues that the GFF and the RMS document wants to reduce is the issue of fragmentation, because we have so much investment, but we do not have the commensurate outputs to show for our investment. So the CSO is also trying to ensure that we have an harmonized system of ensuring that fragmentation that leads to poor implementation and wastages are so capped. And this is what we're doing, right? The CSOs are actually trying to support the agency 3 gateways for basic care provision, from which the money of the GFF will be included, to develop an accountability framework that is quite holistic and brings everybody together. So beyond this, also we are also trying. We are going to be continue supporting the implementation with advocacy. Advocacy not just to the government, but to the private sector, for them to have more meaningful engagement in the process. We're also going to be engaging with citizens. As much as CSOs are the gaps between the citizen and government, we also are encouraging the citizens to have more vital role. So we are creating that awareness across board for more Nigerians to be aware, so they can actually demand quality service, not even just quality, compassionate service from their facilities, because the money is at the top, but it's going to be implemented at the grassroots level, which at the base, which is closest to the people. So we are actually working with these stakeholders to ensure that there's participation, inclusion, and accountability across the entire process of phases of GFF. Thank you.
Thank you very much. I don't know if there's any questions. If not, I think we can round up this session. Thank you very much.
I think the whole essence of this session is to sensitize, inform participants at this conference about the GFF, to pass information of what GFF is all about, so that when you hear about it outside, you too can be, you can carry the gospel. You can extend the information, and you will correctly pass the information to people that do not know or have not heard about it. And if there are no questions, we may want to wrap up this session and move into the other session. I want to thank you very much for listening. Once again, we really want to appreciate all of us that have come so early. It shows how serious we have taken this conference, how much we want to learn. Thank you very much. God bless you.
Please, I think they deserve another round of applause. More so for the fact that the way they managed time, and I think that was very informative. But just to mention that the Nigeria GFF investment case for RMNCH is a sub-component of the NHSDP2 that was launched recently, that was approved by the Federal Executive Council. And I will urge stakeholders here to kindly note the mainstreaming of family planning services into all the different phases that Umar highlighted to us. If you look at phase 1, which is the expansion of the NSHIP project in the Northeast states, one of the things that those states are procuring are family planning services. If you look at the basic package under the BHCPF, family planning is a major component of that. And now that we are moving from 3 states into about 12 states by the end of this year, we are already in phase 3 for the BHCPF. It also means additional opportunities for FP services. With the expansion of the nutrition project in 12 states, it also even means that you now have more opportunities for FP services. And hopefully by the time we get to phase 5, where you want to expand the basic package itself, then I believe that we would have created a whole lot of momentum for FP services. So from where I sit, I see huge opportunities to expand services because now money is available, at least in 15 or so states. as we speak today, the Ministry of Finance will be releasing half of the $150 million of BHCPF appropriated in a few weeks, which is why the minister has expanded the number of states. 57 billion naira is equivalent to $150 million. So now, and I think that's what the next panel wants to discuss. Trust me, if you don't bring on board the private sector, we will not have the traction we require. So I don't know if Effiong wants to start us off with a presentation. You mentioned you have a presentation. Okay, fine. So I'll call on Effiong. Effiong, Country Director Mary Stopes. I'll call on Dr. Ibrahim Kana, Program Manager SOML. Is he here? Dr. Jennifer Ayanti, Deputy MD SFH. Dr. Ibiru Kedada, Safe Care Farm Access. So, in the previous panel, some of the things that's come out, just to summarize, is that 70% of services are delivered through the private sector. But we need to put some corollary to that. Some people will also argue that the quality of care delivered through that channel is in fact questionable. Some other people will say, by the way, if you do not even reduce the kind of technical expertise that is required to deliver family planning services, we will not have the traction we require. How many doctors do we have? How many pharmacists do we have? Maybe we need to go lower down. So those are the kind of things that we would explore with this panel. And just to also inform you, the reason why Dr. Kana is there is that now states have huge money. But that money will not come to them if they do not achieve results. I was in this hall last week where you shared the MCPR indicator on the SOML. There was little or no movement. Yet the states have money. So we will start with you because we're taking a holistic approach to this. What do they need to do in order to be able to move the needle on this? Talking specifically about MCPR in SOML and how they can use the funds they have with both public and private sector.
All right. Thank you very much, Chief Olumide. Basically, there's a huge opportunity really under the SOML for the state to use the resources available to better the lives of women, especially in the areas of modern contraceptives. I say this because the resources available to virtually all the states is that they can use such resources not just to get the FP commodities, but they can use them to also train healthcare workers. They can use them in whatever means possible in their own state that they feel is important for them to deliver these services. We find it very strange with the amount of resources available to them. In the last 2 years, over $200 million was actually disbursed across the states of the Federation. And I can say for sure that no state earned less than $2.5 million. And they are at liberty, free liberty to use the resources, in areas that actually works for them. Of course, one is concerned that MCPR has not been a priority. One is also aware that government as well as major partners have been providing FP commodities. Therefore, all they need is to make sure that these services are delivered to the women. Awareness creation, task shifting, which has been approved. Now, somebody begins to wonder, what is happening? What's wrong with the state? In the last 10 years, people talk about we don't have money at the state level. But now, it is what happened in Nigeria in 1973, where Chief Odoji said the problem of Nigeria is not money, but what? How to spend the money. That's exactly what we're experiencing under the SML before. Otherwise, one sees no reason why our contraceptive prevalence rate is still very abysmally low in Nigeria. The socio-economic and educational status of women is improving every day in Nigeria. This is a fact. But why are we not improving in MCPR? So these are the issues. And therefore, I'm bringing this out now to all the partners working at the state level, that you are automatically members of the steering committee of the Saving 1 Million Lives program for results at the state. You should ensure that they actually deploy their resources in those areas so that we can improve FP services. Thank you very much.
Thank you very much, Dr. Kana. So I go to you, Effiong. So how has the private sector been, what role has the private sector been playing in expanding family planning services in the States? Can you share some of your experiences with us?
Thank you, Lumide. I think the private sector is a non-homogeneous sector, and one thing we know is that they still play a very crucial role in family planning. If we look at it, we've talked about how 60% of family planning in Nigeria is still delivered through this sector. And how we get them to attend, how we build their capacity, how we ensure they are able to deliver quality family planning should be very integral in our national scale-up of family planning. And it goes without saying that if we do it very well, then we'll have a broader national outlook and base for saying we're moving every sector of the economy, of the healthcare sector, towards driving that vision of a very holistic component of delivering family planning. And for us, the work has been building on this. So if I'm sharing Maristop's experience, in 2012, we started engaging the private sector through what we call a franchise model, a social franchise model, where we, up to now, and have really been able to scale up to about 263 of these facilities, build their ability and confidence to deliver quality family planning methods, and also worked with them to build the issue, support them with commodity logistics and continuous quality improvement. And we are seeing the results. If you look at 2017 alone, from our impact study, our impact report, over 142,000 women took up long-acting family planning method from these people. We're talking about private sector here, cutting across 13 states of the Federation. We have seen them manage close to 21,000 post-abortion cases within 1 year. In 2012 now, we're seeing that number increase to about 228,000 women and 31,000 post-abortion care. But let me also bring a perspective that there was a worry about equity around that. And we've seen that with sustained demand generation, we've seen adolescent visit and use of family planning in this same sector improve. Right now, we're seeing out of every 100, 15% of those people that take up family planning from these franchises to be adolescents within the age of 15.
Thank you very much, Effiong. Yeah. I mean, it's very clear that you ignore the private sector at your own peril with the kind of data that you're sharing with us. So, Jennifer, coming to you very quickly. Must a doctor or a nurse be the one to deliver service in this space? And what's your experience telling us?
I think it's a very interesting question, and I think it's one that has been challenging in the country over time. What we found in the studies that we've done is there's a whole sector that's almost ignored. They're there, but people tend to shy away from this particular group of providers, and we call them community pharmacists and patent and proprietary medicine vendors, or your run-of-the-mill chemists. And that's a sector that we found to be responsible for. If you look at 80% of private sector providers, for example, about 70% of them are from this group. And we found out also that about 40% of them are actually health trained. So they have some form of health training. They're either nurses, community health extension workers, community health officers. So a whole group that is available out there, but we've been unable to tap the potential that is in that sector. And remember, they form part of the private sector. And I think over the last 2 or 3 years, we've been discussing with the Pharmacists Council of Nigeria, called PCN, to kind of do an accreditation system for these particular providers. We've been talking about quality in the private sector. People go there. People go to these providers. But how are we going to find a way of accrediting a group of them to be able to provide these services to our women and our adolescents that are out there, that are visiting these people, but we need to improve quality. And I think that's really something that we need to consider as we are planning on scaling up access to family planning in the private sector. It's estimated that there are about 100,000 of these providers out there. In certain states, there are a lot more community pharmacists. In certain states, there are a lot more patent and proprietary medicine vendors. And so over time, Society for Family Health is working, like I said, with the Pharmacists Council of Nigeria and with other partners, including Marie Stopes Farm Access Organization, to work on accrediting these providers so that they will also be available to also provide these services to our women to the right quality, so that when these women do receive these services from these places, you are sure they are the right quality and equity is involved. Remember, equity is an issue. The people who usually go to these providers are bottom of the pyramid women who cannot walk sometimes to their PHC, or who find these people around, close around them within their communities. And so what we've been working on over the past few years is making sure that we get these people involved in providing these services to push up the figures, to move the dial when it comes to family planning in Nigeria.
Thank you very much, Jennifer. In fact, if I wanted to organize a quick quiz to say, what's the total number of pharmacists, dead or alive, on the pharmacy registrar? The pharmacist registrar. Who knows? Maximum 15,000.
Yeah, exactly.
In the public sector, about 2,000. If you go to doctors, it's even worse. But do you know how many CHUs are unemployed today? Random figure. CHUs, unemployed. Who are? Not that much, but pretty high. Pretty high. Pretty high. So, coming to you, Ronke, you work on quality. And everybody is saying, yes, there's capacity in private sector, but we don't trust them in terms of the quality they provide. Can you share with us in 2-3 minutes, what you see in that space?
Okay, when we talk about the private sector, we're looking at the formal and the informal. A lot of work has been done with the formal in getting them to provide better quality of care. Most times, those in the formal sector are actually known to government, so they get more regular visits from the regulators. Unlike those in the informal sector, we recently, I'll give an example. We recently conducted a mapping exercise in Lagos and Kaduna. And I would say that many of the PPMVs were unknown to the regulator. What we found at the end of the day was we had maybe a register of less than 20%, 30% of what we found out there in the field. And it's not just, if you want to regulate, you need to know those who you're regulating. And to know them means that you need to get them into the system, identify them, register them. So what we have tried to do, working in the SFH consortium with Marie Stopes, is to try and identify PPMVs and community pharmacies in the 2 program states we're working, because we're trying to work with the Pharmacists Council of Nigeria to develop a quality system, a stronger regulatory and quality system addressing community pharmacies and patent medicine vendors. And so what we found in the field was, in a state like Kaduna, over 45% of them were actually medically qualified, meaning they were CHUs.
And yet the system doesn't know that.
Yes.
But thank you very much. I just want to Ebere now and say, hey, Ebere. So the partners have a way of working. Sorry, Ebere is a senior health advisor with DFID. He pays my bills, you know. So partners like DFID, USAID, organizations like the World Bank, they have a way of working. It must be public sector. It must be institutions we know. At what point are we going to bring that creativity, that innovation to say, look, there's something going on in the private sector. How can we get the best of the private sector? Otherwise, we come for the 6th National Family Planning about this. I'm just speaking for David and some other partners too.
Yeah, you're right. I mean, the usual thing is to just go with the public sector, but I think many donors have recognized the fact that the private sector is the big opportunity out there, and we've done a lot of work in this area. So DFID has done work in this area, not just in family planning, but in malaria, in maternal and child health, and in other areas. So has USAID, so has Gates Foundation, so has the World Bank. And we've done a lot of work. A lot of the work that has been talked about here has been supported by donors. But we think it is time now to scale up. I think we've had enough, pilots, enough pieces of work that investigates this thing with a few PMVs here, a few private providers here. It's time to take it to the next level. Because the thing is, there is no running away from what the private sector can deliver here in Nigeria. And I think the challenge for us is a system that addresses, I think, 3 basic things that we need to put in place. One is the private sector itself, the quality of service they provide, addressing the fragmentation among private sector providers so that you can actually engage with them and you don't need to engage with hundreds of thousands at the same time. And doing things like providing them access to finance and stuff like that, and improving their management skills and all of that. So that's one thing, addressing the private sector itself and their services and all of that. But then on the government side, we also need to address the regulatory role of government and how the government engages with the private sector and how the government supports the private sector while also addressing, making sure that they deliver quality service. But on the other side, I think that what drives everything is the financing. It's very hard for a government to regulate a private sector if you are not financing, if you are not in control of the financing. And this is where we have a huge opportunity with the Basic Healthcare Provision Fund, which will provide that financing to both public and private. And it will give the government the leverage to begin to actually shape the way the private sector contributes to public health goals. And it's not just private sector in terms of service delivery, but it's across, the whole chain, from supply chain, it's providing ancillary services, it's training of health workers, it's so many things that the private sector can do, but we need to work out a system that enables all of this to fit together.
Thank you very much, Ebere. So you mentioned 3 things. You mentioned regulation. In terms of regulation, we have a PCN that has been extremely responsive, a PCN that has now almost acknowledged the role of PPMVs in this space. And now is how we come together as partners, as stakeholders, to actually take the opportunity available within that reform. You talk about financing, and I have shared with you now 2 different channels that put so much money on the table. We have Dr. Kana there, who has close to $500 million in his back pocket, which is unable to spend. I'm serious. You have the BHCPF, where the minister is saying, look, how do I spend $150 million before the end of the FY? Otherwise, the money will go back to Treasury. And you're talking about service delivery, where we need to look at new models of delivery in terms of human resources or in terms of infrastructure, you know, and several of these things are happening. Maybe we open this to the floor, 2 questions, because we need to go into the next session now. I mean, 2 burning questions. I take one from Dr. Afolabi, Madam Chinwe. Would that be all? Because you need to grill these guys. Madam, I start with you, then we go to Dr. Afolabi. Well, please keep it very brief.
Yeah. Thank you very much for sharing with us the wonderful work you're doing with the private sector, which I believe is going on. But my question is this: how do you engage with the governments, especially at state level, for the governments at the state to know and appreciate and have data in respect to the work you're doing for training and service delivery and other things? Thank you very much.
Dr. Afolabi.
I also like to thank the presenters, the panelists, and the chair. My comment really is on implementation of tax shifting tax sharing policy that has to do with the CHU and the PPMV as well as community pharmacists. Implementing this policy has enabled us to actually increase, like in 5 folds, the service delivery points we have for family planning services in the country. So it's a good policy. However, if we must incorporate the PPMVs, we need to pay more attention to the regulatory as well as accreditation process. And this rests squarely on Pharmacist Council of Nigeria. I think the tiered accreditation has to be assented and become a law before we can proceed at the point where we are. Secondly, the tax shifting tax sharing policy itself, we have to realize as a country that it is a stopgap measure. Every other nation of the world is ultra-specializing. We are talking of tax shifting, tax sharing policies. It's meeting our need now. But in the next 10 years, are we going to be talking of tax shifting, tax sharing policy? I think we need to look ahead and plan. Thank you.
I'll just very quickly respond to the second part, leave the first part to the panel. Sir, for the last 100 years, British Telecoms built underground cables to connect the whole of Britain and several other countries. In the last 10 years, we have mobile telecoms that we need to disrupt. We probably do not have to go the ways of the advanced economies, training super specialists. Perhaps to get to 180 million people, we need to think of new ways, new human resources to deliver service. There was one hand here. I come to Rodio.
Very important, the private sector. What I'm asking is, what about the community health workers? This is another segment that we really need to look at.
Mine is just a recommendation. I would like to use this opportunity to thank Maristop for their wonderful in times of training. I said because I'm one of the master trainer trained by Maristop. They gave qualitative training, and also they gave me training on the case of counseling and outreach. Because in our area before, when you talk of family planning, nobody accepts family planning. They think it's just a woman to stop giving birth. But with their strategy, we changed the name from family plan to child spacing, whereby we tell the woman that for her is to rest for 2 years and any, thank you so much, thank you. My name is Mero Sharif. I'm from Sokoto State, the RH State Coordinator. Thank you.
Dr. Jagu, we are going to close this session in 2 minutes. But that's if you keep your comment to 10 seconds.
Akiode, just want to say that we should carry reporting along, especially for the PPMVs, because we don't want to finish this battle and then start reporting. In other countries, they report from PPMVs into the DHIS.
Well, thank you very much. My worry is, why is it that we have so much money and yet the money is not being utilized? That's the question we should ask. Because I am a practicing obstetrician and gynecologist, and we know the problems we face outside there. There's so much need for the use of this money. All right? You have programs. And okay.
So, panelists, you have 30 seconds. Oh, my God.
Yes. Thank you. I think my comment is that I think we need to begin to actively map PPMVs with primary facilities, with facilities generally, because while we are talking about regulation, regulation ensures that they do certain things right. But again, we need to see actively begin to attach PPMVs, community pharmacists with facilities, that we get good referral.
Dr. Kana, we start with you. There's so much money, there's no improvement in the figures.
That's correct.
Your last words, famous last words.
I think clearly, I would say probably lack of full capacity at the state level to utilize these resources. However, in my opinion, I want to, especially in FP areas, it will be good for the states to explore possibilities of partnering with private sector to deliver the services at the local level. Thank you.
I'd just like to say one thing. There's one health sector. There's no public. There's no private. There's a single health sector. And so what we need to get done is for government to join in not being punitive to the private sector providers, but actually drawing them along in what's going on. And that includes, as was spoken here, we must get them involved in reporting the data back. You must get friendly tools for the private sector to use to report into the government system. You must include them in what we call integrated supportive supervision, so that when you are visiting primary healthcare facilities, visit a nearby PPMV, provide advice, provide support, so that we are working in one health sector, so that as we are working on improving these figures, the private sector is carried along in a way that is inclusive and includes investment and access to finance.
Lastly, I will talk about the role of technology in what we should be doing in terms of the private sector. I think at this point we should be thinking of how to get them to report using some simple app or device, and that's something we're already working on the SFH consortium. And beyond that, we're also looking at introducing an SMS technology to promote client follow-up, because it's not only to give them commodities, but to be sure that they come back for their regular appointments.
I just want to say that successful partnership is needed to increase, to get a national impact. And we need to do this together. There should be no public and there's no private sector, from commodity distribution to share experience. But I also want to say, and I don't know, that please, we need to put a voice together and get the president to sign the pharmacy bill before him. That will help us deepen our work with the public sector.
Yeah, just to say that if you look at Nigeria in terms of service delivery, finance, and so many other things in the health sector, you find that you have a small public financing, small public service delivery, but large private out-of-pocket financing, large private service delivery, that's not necessarily contributing as much to public health goals and not efficiently being used. I think the challenge before us as a country is how do we create a system that converts that private financing, even though most of it is out of pocket, to and the private service delivery to contribute to public health goals.
On that note, ladies and gentlemen, a round of applause for my panelists. They've done very well. Thank you very much. Benjamin Lovins.
Thank you.